So this is a 62 years old lady, came to us with acute type B complicated aortic dissection. You could see here the problem starting in here with a huge aneurysm and the falls in the true lumen. The problem that she has the left kidney coming from the false lumen, and there's no perfusion at all in her legs, rest pain, cannot walk, and severe interscapular pain. We kept her in for 82 hours in the ICU, tried to control the pain and to drop her blood pressure, but of no avail. So what we decided to do, as you could see in here, we need to get a landing zone. So we're going to put a Shivar into her left subclavian. At the same time, we're going to allow the perfusion of both internal iliac, and let's see what happens. So we went and we tried to go through the compressed lumen. It was impossible to go in here. We used the transesophageal echo, as you could see in here, in order to get from here to there. It's just like you have hitting a wall. We kept at it for a few minutes until we were able to pass the wire, and when we passed the wire and the pigtail, we were able to go up. We have to pass from the true to the false lumen into the left renal, because there was a dynamic obstruction here to save the left kidney, and we parked the Aptos sheath over there. And then after that, we went on and we fired our stent under fibrillation of the heart. And as you can see in here, the stent haven't been opened because the compressed true lumen was less than 1 millimeter. So we decided to put an extra stent just above the celiac axis in here in order to allow the perfusion. And you can see all the time we have the Aptos into the left renal so that we do not lose it because of dynamic obstruction. We put the third piece in here, and we have the Aptos. We put the pently in here to occlude the dynamic obstruction of the left renal artery. And then after that, we went on to try to see what's happening. Still, there's some perfusion in here, and you can see the compressed true lumen into the infrarenal aorta. And because the length from the lowest renal to the bifurcation was 80 millimeter, we decided to use an AFX supplemented with a proximal Incraft stent. So we put the AFX in here. That's the Incraft 34. You can see the left renal and you can see the distal end. However, there's still perfusion in here, so we use a Jotech aortic stent. It's 40 above it and 36 distally, and it's 130 in order to allow modulation. And as you can see in here, we put 2 stents of pently aortic in both common iliac in order to secure the feedback from over there. This is a completion angiogram. You can see the Shivar with the left subclavian working perfectly, and you can see everything looks hunky-dory. And then this is the follow-up. Patient looks perfect, no paraplegia, no renal failure. She went home within 5 days. However, the whole idea in here, if you have to have everything available for you. So we use a Gore graft, which is the best for the arch because it's comfortable and you could rearrange it again. And we have used a pently into the subclavian and into the renal. We use an AFX because of the short aorta. We have used Incraft aortic cuff. It's a teamwork. However, you cannot do it without having a proper endosuite and a transesophageal echo.